Thank you, Felix. Yeah, really great to be here and to participate in this patient day, which has been excellent so far, and I hope continues to be so. We're going to hear from Dr. Rakesh Sharma, who's the lead for cardiac sarcoidosis at the Royal Brompton Hospital, which I believe is probably now the biggest and most expert cardiac sarcoid centre throughout Europe, but I'll let them speak for themselves in that regard. But first, I think I'd like to introduce my co-chair, Dominic Lawrence. So Dominic, would you like to come to your video? And I believe you have a video, a short video to show. Is that right, Vasilis?
That's right.
Hi everyone, my name is Dominic Lawrence. I am a patient of cardiac sarcoid. I was diagnosed in 2016. And I just want to extend my thanks to the team at Sarcoidosis UK and the team at Royal Brompton for setting up today's event. So it started off my symptoms with a persistent cough, which I had for years, and nothing that the GP prescribed would work. I then was referred to a respiratory consultant who, again, after lots of checks and tests, thought it might be either nasal drip or asthma or acid reflux, and gave me treatments for all of those things. But during those tests, I was also found to have atrial fibrillation, so I was referred to a cardiologist who carried out a couple of ablation procedures over the next 6 months. In December 2016, unfortunately on holiday in Bangkok, I suffered from complete heart block. And it was only thanks to the fact that I was a block away from a top hospital that I actually made it through that event. They installed a pacemaker, and I returned to the UK a few weeks later to try and find out what caused the heart block. I had a number of tests, from chest x-rays, CT scans, PET scans, MRIs, EBUS and a mediastinoscopy, and finally was diagnosed with sarcoidosis after a lymph node biopsy. I then referred myself to Professor Wells at the Brompton because I felt that I was struggling to find somebody who understood sarcoid, who immediately involved Dr. Sharma, and I was admitted for IV steroids, and my pacemaker was upgraded to a ICD. I then started a course of prednisolone, which I was not really responsive to. So I was then given methotrexate and hydroxychloroquine as well, which again, I was not really responsive to. And finally, speaking to Dr. Karanos, I took infliximab. And finally, we found a treatment that worked for me. And after a course of infliximab, there was evidence that sarcoidosis was clearing up, which is fantastic. And I am still taking infliximab today.
Thank you, Dom. That was a really nice run through of a fairly typical presentation, I think, really. And I'm sure Dr. Sharma will tell us all about the lack of awareness outside of specialist centres for cardiac sarcoidosis and how important it is to be aware of that diagnosis. So, Rakesh, I'll hand over to you. Thank you.
Thank you very much, Peter. Thanks for that introduction. So I must say it's a great privilege to take part in these patient event days. So we all as doctors do lots of different meetings and seminars, but I must admit the patient days are my favourites. I'd like to also thank Sarcoidosis UK and Vasilis for all their hard work putting together such a fantastic programme. So I'm going to share my screen. So hopefully that appears on your screens. So yes, so I've been asked to talk about cardiac sarcoidosis, which is actually my main kind of subspecialty interest. And in particular, how as patients you can involve yourselves in the care of this disease, and also how as doctors and other clinicians we can be more aware of cardiac sarcoidosis and try and identify it and treat it at a very early stage. So I'm going to share a screen which I've shown at previous meetings, but just to highlight that sarcoidosis is a multi-system disorder. So what this means is that sarcoidosis can affect different organs in the body. The most common being the lungs, which is why respiratory physicians very often will see the vast majority of patients with sarcoidosis, but also can importantly affect other organs as well, such as the eyes, the brain, the liver, spleen, joints, and also the skin. So this means that patients can present to specialists via different subspecialties. So all of us need to be very much aware and vigilant of this condition. Certainly when sarcoidosis affects the heart, this is when things can become quite urgent and sometimes life-threatening. So I'm going to touch upon some of the different modes by which patients can come to our service. So I thought I'd start by presenting a patient who came to us last year. So he's a 46-year-old gentleman who is very fit and active, and in fact was training for a marathon when he had a faint. So he basically lost consciousness. Now, a passerby commenced CPR, and then the paramedics were called, and the ECG which was performed showed a condition called ventricular tachycardia, which is basically one important cause for cardiac arrest. So he received a shock and the rhythm was restored back to normal, and then he was taken to the hospital. Now, whilst in hospital, there was a skin lesion which was noted, and a biopsy was taken of the skin lesion, which confirmed that the patient had skin sarcoidosis. And based on that, and also the presentation, he's referred for specialist scans to our unit. Now, when it comes to diagnosing cardiac involvement of sarcoidosis, one of the key tests which we will perform is a cardiac MRI scan. So cardiac MRI is often used for a variety of different conditions within cardiology, but for cardiac sarcoidosis is one of the key tests which we'll do. And the reason for that is MRI is a very good test to look for scarring in the heart. Now, unfortunately, with sarcoidosis, because it leads to inflammation, that can subsequently lead to scarring. And in order to detect scarring, we would give an agent called gadolinium at the time of the MRI scan. So if you look at the top panel here, this is looking at the heart in a cross section. And if you look at the bottom panel, this is a longitudinal section of the left ventricle. And the areas which are highlighted in white, those are the areas which illustrate scar. Now, sometimes just the pattern of scarring alone can be highly suggestive of cardiac sarcoidosis and can help us make the diagnosis. But very often we need other investigations as well, and also the team-based approach to try and help us understand if a patient has cardiac involvement. So another key test which we'll often do to try and make the diagnosis is a PET scan. Now, PET-CT is basically done with using an isotope of glucose, which is radio-labeled, and that is taken up in actively inflamed tissue. So with PET-CT, we get to look at the heart, but also other organs in the body, such as the liver, spleen, lymph nodes, and so on. So it's a very, very good test to look for cardiac and extracardiac inflammation. In order for the PET-CT scan to be helpful, we will ask patients to undertake a prolonged fast, and that's very, very important because what we want to do is we want to suppress physiological uptake of glucose within the heart. So any signal that we see, we can be sure is due to true active inflammation and not a false positive result. So for this particular patient, we can see these areas in yellow and orange, which represent areas of active inflammation. So because the patient had a clear diagnosis, which was made following an MDT discussion, he underwent implantation of an ICD to try and protect him from further episodes of ventricular tachycardia and cardiac arrest. And because of the active inflammation of the heart, he was given intravenous and then oral steroid therapy with a view to suppressing further fibrosis. So how can patients present to us? Well, this is an elegant registry which was conducted in Finland and looked at patients over the course of 17 years. And so they had just over 350 patients. So as I've presented with the case just discussed, VT is an important mode of presentation, but the most common mode of presentation is as what happened with Dominic. So advanced heart block or complete heart block in this registry occurred in about 40% of cases. But sadly, some patients may present with sudden death, which means clearly the diagnosis has been missed and it's made after death. So this is something which we really need to avoid and improve on. Heart failure is another important mode of presentation. So what can we do? Well, this is a slide which I often will present at international meetings and national meetings to try and educate my cardiology colleagues that we really need to be more vigilant in detecting sarcoidosis early, because in this registry, unfortunately, 2/3 of the deaths were actually in patients who had hidden disease or where the diagnosis was actually completely missed. And there's several advantages to diagnosing the condition early, mainly because if we can detect cardiac sarcoidosis before it causes scarring, then we can hopefully prevent the onset of heart failure. And it's often the kind of inflammation and scarring in the heart which leads to the conduction system problems, the heart block, the VT, and the cardiac arrest. So with any inflammatory process, we need to try and improve our diagnostic pathways and strategies to try and detect patients early on in their natural history rather than waiting for patients to present later on. And this presents us with several challenges as clinicians. So in terms of modes of presentation, we can broadly subgroup patients into two categories. Those who have no symptoms of cardiac sarcoidosis, but are picked up because of some incidental findings. So for example, at the Brompton Hospital, where we have one of the largest in-situ lung disease units in the country, a lot of my respiratory colleagues will be having a high index suspicion of cardiac sarcoidosis if the patient has extracardiac disease. So if they have, for example, an abnormal ECG, or if for some reason they refer for an echo and it's not quite right, then patients come to us and then we will do further tests to see if the patient has cardiac involvement. Another mode of presentation is when patients are having a cardiac MRI scan for another reason. So as I said earlier, cardiac MRI scans are performed up and down the country for patients who've got coronary artery disease, patients with valvular heart disease, cardiomyopathies, and so on. And sometimes a pattern of fibrosis in the heart may alert the reporting MRI consultant or cardiologist looking after the patient that the patient may have cardiac sarcoidosis. So this is a very important mode of referral. And again, we're trying our best to educate colleagues in cardiology and MRI that we should be looking at patients more closely if there's a pattern which could be suggestive of cardiac sarcoidosis. But patients may clearly also have symptoms. So what kind of symptoms may patients present with? Well, sometimes patients will have palpitations or dizzy episodes if there's involvement of the conduction system. Fainting or syncope is a very important symptom. You've heard from Laura Price about the importance of syncope when it comes to pulmonary hypertension, but certainly in the patient with sarcoidosis, if there's syncope, we really need to look hard for a cardiac involvement. And also, there may be other non-specific symptoms, fatigue. Fatigue, you'll be hearing about that in another session this afternoon, but certainly is a very difficult symptom to try and work out what the cause may be. And sometimes it can be due to a low heart rate or conduction problems. Sometimes it could be due to other reasons. So again, it needs investigation. Certainly, if patients have heart failure, then they may present with breathlessness. Very often, this means that the condition has been missed for some time because heart failure tends to occur in patients with sarcoidosis where there's fibrosis and change in their cardiac function. And certainly swollen legs or edema may be another manifestation of heart failure, but also could be due to the pulmonary hypertension if they do have it and right-sided problems. So how can we as a team make a diagnosis? Well, with sarcoidosis affecting the heart, unfortunately, there's no single blood test, and very often there's no single imaging modality which can clinch the diagnosis. Which makes it very challenging, but also means that we need to work as a team to try and put together different pieces of the jigsaw so that we can see exactly what the condition is. If we just have one results, for example, just a PET scan, or if we just have a CT scan result, it may not be enough to make an accurate diagnosis, and alternative differentials may be missed. So it's important to look at a comprehensive assessment when sarcoidosis is suspected in an individual. So at the Brompton Hospital, I'm very fortunate to work with excellent colleagues. We've heard from Athol Wells and Vasilis Karanis. We've got excellent colleagues in imaging, without whom we would not be able to run the service. And we've got a specialist nurse, and we're looking forward to recruiting an additional nurse. So it really is a team-based approach, not just in diagnosing the condition, but also in the monitoring and the follow-up. I also say to my patients, it's a chronic condition. The aim is to push it into remission, but it's very difficult to say that we've cured patients. So this means that patients do need support throughout the whole of their journey, and we need to be there for them. So that involves us being not just doctors, but psychologists and support workers as well for our patients. So coming back to the multidisciplinary team approach, well, this is something which we've pioneered at the Brompton Hospital. It's now a model which has been replicated in other units and across the world. And we've been able to publish the success of this model. And it's particularly relevant to cardiac sarcoidosis because of several different reasons. Well, first of all, cardiac sarcoidosis is a relatively rare condition. So when we look at other diseases affecting the heart muscle, cardiomyopathies, for example. Traditionally, the incidence will be 1 in 500 up to 1 in 3,000 patients. For cardiac sarcoidosis, it's difficult to be accurate with the numbers, but we're looking at roughly 1 in 10 to 50,000 individuals. So the order of magnitude is much rarer. And also, sarcoidosis can mimic other conditions. So whenever we discuss patients in our meeting, we really need to think about other important conditions which may be more common and which can also present in a similar way. So one important differential diagnosis which we often discuss is arrhythmogenic cardiomyopathy. So this is a condition which affects between 1 in 3 and 1 in 5,000 individuals, where patients can get weakening of the heart muscle, usually the right heart, but sometimes the left heart. And this is a kind of PET scan in a patient with AVC. And just looking at the scan, it's difficult to know whether this is sarcoidosis, is it a cardiomyopathy, is it dietary failure? It's difficult to know. So this is why I always emphasize the MDT approach is the key to try and make an accurate diagnosis. As I said already, there's no single test which can confirm the diagnosis, and we really need to put everything together. And the advantage of the MDTs, we've got consultants and specialist nurses with different skill sets, and they can bring their knowledge to the table, and we can try and give the best diagnosis and most accurate diagnosis for patients. And also it's important, as we discussed, that patients can present in a variety of different ways. So very often at MDTs, we will involve our rheumatology colleagues, sometimes neurology and so on, to try and gain understanding of other organ involvement. And as patients can present to other specialists first, very often we'll try and include them in our MDT meetings so that we can also make a joined up management plan. Another thing which I think is important to realize is that with cardiac sarcoidosis, we need to keep an open mind. So if we have a patient with biopsy-proven extracardiac disease, so for example, someone with lung sarcoidosis, and there's a suspicion that they may have cardiac involvement, certainly we would do the usual tests, but at the end of the day, even if we detect there's no cardiac involvement at this point in time, it doesn't mean that we should ignore symptoms in the future. So patients and clinicians should be vigilant that things can evolve, and certainly what may not be evident on an MRI scan today may become evident in 4, 5, or 6 years' time. So this is something which we need to always bear in mind. So we can't definitively exclude cardiac sarcoidosis forever in a patient with extracardiac disease. Now, we've touched upon this just briefly, and Felix very eloquently talked about COVID-19 in general sarcoidosis. Certainly through the pandemic, we've been trying to keep close to our patients because it was a very difficult and worrying time for individuals who were taking immunosuppressive drugs and with this virus for which we didn't have a cure or treatment in the beginning. So yes, obviously patients can develop COVID with a background of sarcoidosis, and sometimes the symptoms can be difficult to differentiate from cardiac disease or cardiac sarcoidosis and COVID. So this is a patient who came to us with a background of cardiac sarcoidosis, having had an ICD implanted several years ago following a cardiac arrest. And in fact, her symptoms were stable until March of last year when she began to get palpitations and chest pains and fatigue. So just based on the symptoms alone, it was difficult to know whether this was actually exacerbation of a sarcoidosis or whether there was something else at play. And very often the questions that we get asked from our patients, and certainly throughout the pandemic, we've been trying to keep close to them, is first of all, are patients more susceptible to contracting COVID-19? One of the things which we found for the cardiac sarcoidosis population is that thankfully we haven't seen very many patients with very severe disease. And I think this could be because of low-grade immunosuppression that some patients have been taking, but certainly patients should be flagged up as being high risk, and they should be offered the latest treatments and antivirals promptly to try and prevent more serious disease. But thankfully, what we have seen throughout the pandemic is that for some reason, patients have been protected if they've been taking low-grade immunosuppression. The treatment options, again, I don't think I'll talk about this in this particular talk, but certainly it's important that we work with our respiratory physicians, immunologists, and also imaging specialists to try and improve treatment and management plans. Just to finish on a couple of slides, so COVID can lead to myocarditis, as can other viruses, and sometimes the pattern of fibrosis in the heart can be difficult to differentiate with cardiac sarcoidosis. And just yesterday, we had a pediatric consultant present a 12-year-old girl in our meeting yesterday, and she presented with a cardiac arrest at school. And she contracted COVID in October, but actually when we looked at the MRI scan, although the features were suggestive of sarcoidosis, by having the multidisciplinary team approach, putting together all the information, we thought that this is more likely a rare complication of COVID myocarditis rather than sarcoidosis in that young individual. So I'll just, I think, skip over this slide really because it's quite a complicated slide, but just to say that we do have a pathway. It's important that patients are followed up in tertiary centers with a high volume of experience in managing patients with cardiac sarcoidosis. Very often we will get patients referred to us from up and down the country and also from abroad. And I think with rare conditions, it's very, very important that we have national services try and help put together not just clinical expertise, but also research programs. So I think I'll stop there in terms of the presentation, but very, very happy to take questions and to participate in the discussion. Thank you.
Thank you, Rakesh. Wonderful talk. Generated lots and lots of questions on the chat. But I might just come to Dominic first. If you do you have any pre-arranged questions that people have sent in, or shall I go to the live ones?
I've got a couple of questions here. Good afternoon, everyone. One question is, how do you monitor the progression of cardiac sarcoidosis? What tests should I expect and how frequently? In other words, how do I know if my cardiac sarcoidosis has gone away? And how will I know if it's come back?
Yeah, so very, very good question. So monitoring is an important part of the treatment because, as I said, it's very difficult to say we've cured someone, so patients will need ongoing monitoring. So very, very basic things like, for example, an echocardiogram would be important just to monitor the cardiac function and to make sure that the heart function has not declined. Blood tests can be used for monitoring as well. So there's a protein called BNP or N-terminal proBNP, which can go up if there's a buildup of stress within the heart. So that's a good way of monitoring, and we've been shown to predict outcome with that. Other more advanced imaging modalities also used. So MRI scans to make the diagnosis, but also for follow-up can be helpful. Can be challenging in patients who have devices, but we do have a program at the Brompton for doing MRI scans, even if patients have non-MRI conditional devices. So we do use MRI. And then finally, PET. I think PET is crucial, especially if patients have had a flare-up of the cardiac sarcoidosis and they're on steroid therapy. The question is how often, because obviously there is some radiation exposure. So we try and space out the PET scans. But even if patients don't have symptoms, what we have found is that if they're taking immunosuppression, they should have a follow-up PET at some point in the future because there can be a flare-up even if they don't have symptoms. In terms of lung tests, obviously I'll yield to Athol and Vasilis about this, but lung function monitoring is going to be important to look for lung involvement and progress really.
Dominic, thank you, Rakesh. Dominic, do you want to answer your second question?
Sure. The second question is, is there a standard maintenance immunosuppressant or other regime to keep cardiac sarcoidosis at bay once the initial disease has been subdued?
Okay, so I'll probably involve Vasilis or Athol on this question because when it comes to immunosuppression, it's normally my respiratory colleagues who would lead on that. So Vasilis, do you want to answer that question?
Yeah, I would say that thanks Dom, and thanks to all the patients that are so actively have participated. I'm not sure that everybody knows that patients have sent a lot of questions to their advocates in the chairing session, so they have collected questions. So I just want to say that to answer that question is that at the Brompton, we have traditionally used the steroid-based approach in treating patients with cardiac sarcoidosis, primarily because it is far more effective and far more quick in effect type of treatment. However, we wouldn't hesitate up titrating second-line agents such as methotrexate, azathioprine, and less often mycophenolate for the treatment of cardiac sarcoidosis. And unfortunately, we have had some refractory cases where we had to use infliximab, but hopefully this has shown excellent effect in our patients. So we try to use as much as immunosuppression we can in cardiac sarcoidosis because we know that the level of immunosuppression should be higher in this particular form of the disease.
Thank you, Vasilis. It's actually time to move on to the next session. There are 5 unanswered questions in the Q&A chat. So perhaps Vasilis and Rakesh, if you have some time, if you could perhaps just specifically write a few words for those. then everybody can see the answers. That would be very helpful. And just to thank Dominic, my co-chair, that was wonderful. We very much appreciate your time and involvement, and Rakesh for a really excellent talk, as always.